In this module, we're going to review infections, hemostasis, and suture removal. Many years ago, periodontics was thought to need to be performed within an operating room environment. In reality, all we need to do is follow proper aseptic technique. What this means is to have a sterile perioperative field, make sure we're using sterile instruments and gloves, be sure to utilize a preoperative mouth rinse such as chlorhexidine, and consider preoperative medications such as antibiotics or steroids. Let's focus a little bit on that preoperative mouth rinse. Multiple studies have shown a dramatic reduction in the amount of oral bacteria lasting up to an hour following a single 30-second rinse of chlorhexidine. From a standpoint of non-surgical therapy, Listerine has been shown to be equally as effective. However, from a surgical standpoint, we want to use the chlorhexidine mouth rinse. Preoperatively, we need to consider using antibiotics whenever we might be considering any type of bone graft procedure. In addition, for our larger, more major procedures, we might need to consider getting on a steroid prior to the procedure beginning. Typically, what is given is either a Medrol dose pack or by giving dexamethasone through an intravenous route. Now, the rate of infections post-surgically is really all over the board. However, two studies that looked at this particular aspect of postoperative care is the one by Pack and Haber and one by Chechi. And as you can see, the range between these two is anywhere from 1 to 5%. Several things are interesting when you look at Pack and Haber. One, it was a low infection rate, and actually there was a greater infection rate by 1% when antibiotics were given. The most definitive study, however, in looking at infections post-surgically was published in 2005. This retrospective study reviewed 1,053 surgical procedures which were performed by residents and faculty at Wilford Hall Medical Center. From these procedures, only 22 infections were noted, which correlated to an infection rate of 2.09%. Again, much like the Pack and Haber study, patients receiving antibiotics pre and post-surgery received a higher rate of infection, as you can see, at a 2.85% rate. Patients not receiving antibiotics had a 1.81% infection rate, and in one of our procedures where we typically give antibiotics pre-surgically, dental implant placement, the infection rate was 1.15%. The bottom line from this that you need to take away is that there is a low rate of infection following periodontal surgery, and use of antibiotics to prevent infection is not really warranted. However, in the cases of implant placement or bone grafts, pre-surgical antibiotic should be utilized. Now, one of the things that we want to do to help minimize any kind of adverse healing event is to carefully manipulate any of our flaps. This means that we need to have sharp, smooth incisions on dissection. We need to make sure that we have adequate flap release so that we're not putting too much tension on that flap as we're retracting. And we need to pay attention to the vascular supply. And we do this by ensuring a proper flap design, and in instances when we need to remove connective tissue, avoid over-thinning the flap. You remember from your past periodontal courses that epithelium itself has no direct blood supply, and so connective tissue is necessary to nourish it. In addition, anytime we might have a perforation or tear will interrupt the vascular supply to the actual flap, and so we need to avoid that. We'll look a little bit about flap design in an upcoming module and talk about how to preserve maximum blood supply to your flap. Also, we need to make sure that we don't desiccate the flap in the bone. We don't want this to be a desert dry environment. Now, surgical hemostasis is an area that starts right from the review of the medical history. We need to look at the potential medications that our patient is taking and any potential coagulation disorders and factor that into our management of the patient. In addition, intraoperatively, we need to utilize several things to help manage the hemostasis. One is to look at what we do post-surgically, and that would be applying pressure to the flaps. In almost all of our procedures, we recommend applying 5 minutes of digital pressure to the flap at the completion of the surgical procedure. In addition, vasoconstrictors can be used as a temporary measure but should not be relied upon to maintain hemostasis control after the patient has left the office. Local agents such as Surgicel, Avitene, or topical thrombin can be used in cases where we're having more difficulty controlling the bleeding, or for example, if a patient is taking an anticoagulant such as warfarin and they have a higher INR number, such as a 2.5 to 3 range. Now, one study that looked at the amount of blood loss that occurs following periodontal flap surgery was this study by Bob in 1977. On average, 134 milliliters of blood was lost from periodontal flap surgery, but you can see there was a huge range. Duration of the surgery and the amount of anesthetic that was used correlated with blood loss, with more blood loss seen in mandibular procedures than in maxillary procedures. The takeaway from here is to make sure that you're using proper management, making clean incision lines, and utilizing all your tools to minimize any potential blood loss post-operatively. On that subject, we need to make sure we're having our patients do one thing for us, and that's rest. Many times patients want to resume their normal daily activities, and we have to precaution them that following the procedure, it's best for them to go home, relax, and not get their heart rate up. In addition, it is our responsibility to make sure that we have proper wound stability so that we don't induce any post-surgical bleeding. This goes back to making sure that if we need a topical agent, we've used it, and also that we've used our digital pressure to stabilize our flaps. Now, one of the big things that we're looking for in order to maintain hemostasis is to obliterate dead space. And dead space is simply just a space where a potential blood clot could form underneath the flap. The digital pressure that we apply establishes that initial fibrin linkage. And because of this, we should maintain good hemostasis throughout our course of healing. Now, we also maintain hemostasis and make sure that we obliterate our dead space by having primary closure of our flaps and by sometimes our suturing techniques that we utilize, which we'll cover in a future module. Now, wound stabilization starts with flap adaptation and making sure that we have good hemostasis. Again, we need to apply the appropriate suturing technique to the situation. Many times we'll utilize a compression type of suture, which will help adapt the flap and eliminate that dead space. Additionally, we need to caution our patients to be careful with these areas, and this means limit their oral hygiene or make modifications for it. We need to have a proper timing of our suture removal. We need to caution them about the appropriate diet, and sometimes we need to consider a periodontal dressing as well. We don't want to rely solely upon that periodontal dressing, however, to maintain our hemostasis. While we're on the subject of that wound, hemostasis, let's talk about how quickly a site will heal. Now, the data that you see here is presented from a study that was done by Bill Hyatt and published in 1968. He did this study in a dog model, and essentially what he did was reflect a flap, replaced it back, and suture the area. At the time points you can see here on the left, at 0 to 1 day, 3 days, 14 days, and 21 days, he placed a suture in the flap, attached it to a tension device, and looked to see how much attention it took to displace that particular flap. You can see through those days, when they did histology on these, what type of attachment was present. At 1 day, we just had the fibrin linkage and clot adhesion. By 3 days, granulation tissue was being seen. At 14 days, there was an epithelial attachment and actual collagen adhesion. And by 21 days, we had maturation of the connective tissue. Now, as actual numbers that you see here from the various time points and the amount of grams of force it took to apply really guide us as to when we should remove our sutures. If you're looking at this data, you can see that at 7 days, our flap is still fairly weakly applied to the gingiva, even though we've had that time of healing. We have Great materials today for suture, which we'll cover in another module. But bottom line is, the longer we can leave those sutures in, the better. You can see the dramatic increase from 7 days to 14 days in the overall flap strength. One other study that backed up this data was done in mini pigs and published in 2009. Again, this study involved flap reflection for the control with replacement of the flap. And the test side, you received flap reflection, placement of platelet-rich plasma, and then replacement of the flap. The idea here was to see if the platelet-rich plasma enhanced the wound stability and the healing rate of the particular flap wound model. So you can see here, as we're looking at our control in our test through day 2 through day 7, there's an increase in flap strength, but much like mirroring Hyatt's data, as we're getting out into the later time points at around 14 days, we're beginning to see greater and greater wound strength. The only time that there was a significant difference, however, was that between using PRP and not using PRP underneath our flaps, was looking at the difference between day 2 and the later time points. Again, our takeaway here is that we need to look at leaving our sutures in place longer than that 7-day time point, and more considering outwards of 10 to 14 days before we would consider suture removal. I hope you've enjoyed this module, and we'll continue on with incisions in our next module.